Hey everyone, good afternoon. My name is Brian Olenichek. I am one of the newborn business development managers here at USDTL, and I just wanted to thank you all for joining us today for another installment of our ToxTime webinar series. If you are new to our ToxTime series, welcome everybody. Today's topic is going to be with Ms. Guida Brown. She will be presenting on the Fetal Alcohol Spectrum Disorder. So a little background on Guida. She does serve as the Community Relations Consultant for USDTL here in Illinois. She also serves as an adjunct member of the faculty at Concordia University, the UW-Parkside, and the Gateway Technical College. She has also been the executive director of the Hope Council on Alcohol and Other Drug Abuse for over 13 years. She is certified by the state of Wisconsin as a substance abuse counselor, a fetal alcohol spectrum disorder trainer, and an intoxicated driver program assessor. And helping to moderate our live Q&A today, we have our newborn account development manager, Ms. Carissa Little. She will be joining us here shortly. And we will pass this over to Guida Brown. Thank you, everyone, and enjoy.
Hello, I'm Guida Brown. I'm the Community Relations Consultant for U.S. Drug Testing Laboratories, as well as the Wisconsin Certified Fetal Alcohol Spectrum Disorder Trainer. And I'm pleased to be here to discuss identifying and treating those with fetal alcohol spectrum disorders. Our learning objective is to learn the components of identification of fetal alcohol spectrum disorders and referral services or case management for those with fetal alcohol spectrum disorders. Our learning goals are to identify FASDs across the lifespan of individuals, to describe the developmental and functional concerns for those with fetal alcohol spectrum disorders, and to learn about interventional approaches. To start, the overview of FASDs. Individuals affected by prenatal alcohol exposure can have a range of serious lifelong problems, including physical, cognitive, behavioral, and social deficits. That's not to say that they're going to have all of those, right? They're going to have physical and social, or behavioral and physical, or they could have physical, cognitive, and behavioral without social. So that's sort of the disorder aspect of it. It could be all of those things. It could be two of those things. It could even just be one, which of course causes problems for diagnosing. Speaking of diagnosing, fetal alcohol spectrum disorders is not a diagnostic term. It's the umbrella term that describes the range of effects that can result from prenatal alcohol exposure. Fetal alcohol syndrome is, in fact, a medical diagnosis, and it's usually made by a dysmorphologist, a clinical geneticist, or a developmental pediatrician. I want you to keep that in mind, that one of those people, and actually a lot of others who are a doctor level person, can make a diagnosis as long as they are appropriately trained. FASD by other names. We call it fetal alcohol syndrome when it's the full-blown facial changes fetal alcohol syndrome. It's neurobehavioral disorder associated with prenatal alcohol exposure. There's partial FAS. There's alcohol-related birth defects. And there are specific criteria that need to be met for the FAS and more recently for the NDPAE. However, research continues to provide more clinical clarity for all conditions within the spectrum. We don't call it FAE anymore. We don't call it alcohol-related neurodevelopmental disorder. And I don't expect you to remember any of these terms, but aside from FAS, quite honestly, because they change pretty quickly. When I first started working in this field, we did call it FAE, the fetal alcohol effects, and that was for people who had some effects, but not the full-blown fetal alcohol syndrome. The prevalence of fetal alcohol syndrome, based on CDC estimates, is that the rates are comparable or greater than Down syndrome and spina bifida. So I would guess that more people know about Down syndrome than know about fetal alcohol syndrome. So that tells us we're not doing a great job getting the message out there, especially since this is the #1 preventable cause of mental disability in the Western world, drinking during pregnancy. So other methods, however, have shown a much greater prevalence for FAS even up to 5 times more, which is hugely significant. And then there are those folks who believe that FAS might just be the tip of the iceberg, and the full range of fetal alcohol spectrum disorders may occur as much as 10 times more than FAS. There was a JAMA study in 2018 that said that the estimated prevalence of fetal alcohol spectrum disorders among first graders in 4 U.S. communities ranged from 1.1 to 5%, using, again, a conservative approach. And there's another study just came out recently that says the same thing. It's about 5% of the population. What that means is that every school, every classroom has at least one child who has an FASD. Probably more because those are conservative approaches and because we're not doing a great job diagnosing them at all. So I know you can't really read this, but I don't want you to. I want to draw your attention to just that first column. The very top, it says FASD, and it shows what all of the disorders under, or all of the characteristics under that can be. Moving over, so the light blue is ADHD and ADD. The next one over is sensory integration disorder. Then the blue again is autism. The pink is bipolar. The green is reactive attachment disorder. The gray is depression. The purple is oppositional defiant disorder. And then there's trauma and poverty. All of these disorders have overlapping characteristics. But even more importantly is that all of these other disorders look like an FASD in some respects. So what's happening is that children are being diagnosed with this other thing, in part because it's easier to treat. There's not as much stigma that goes along with it, and there might be a pill that will resolve at least some of the problems. So we're getting a lot of ADD, ADHD, autism diagnoses that might not be accurate because we're not looking at the big picture. So what is really happening is we're getting diagnoses for a cough when we really have pneumonia. So who has babies with fetal alcohol spectrum disorders? Well, pretty much anybody can. And again, there's a huge stigma that goes with this, but not everybody knows that they're pregnant as soon as they get pregnant, right? So the prevalence of women who are in childbearing age and drinking is pretty significant, pretty high. Some states higher than others. I'm from Wisconsin. We're doing really badly. Women in childbearing age drinking. And that's just drinking. Here is women in childbearing age binge drinking. Now, binge drinking is identified as having 4 drinks in a 2-hour period for most women, this age women. So 4 drinks in a 2-hour period is considered binge drinking. And again, Wisconsin, Illinois, up here in the Midwest, we're not doing great. We're not doing great at all with the binge drinking. So again, it's bad enough that women aged 18 to 44 are doing a lot of drinking and a lot of binge drinking, but here's the really scary statistic. They're actually drinking while they're pregnant. This was a self-reporting study that was done, and women who were pregnant between the ages of 18 and 24, 16% of them, again, self-reported. I don't know that that's an overly reliable number, so I'm guessing it's more. 16, almost 17% said, yes, I'm drinking, and 8.5 said, yes, I'm binge drinking. So really scary. Again, those numbers go down until we get to the 35 and 49 age gap, and it's again 17%, so super high again, and 4.4% of them are binge drinking. Again, an episode of binge drinking for women of childbearing age is defined as 4 or more drinks in about a 2-hour period. but anything over 1 drink per day for women is considered to be over the moderate drinking level. So moderate drinking is no more than 1 drink per day for women, 2 drinks per day for men. That's it. We used to have 7 drinks in a week and 14 drinks, and it's not anymore. It's 1 drink a day. If you drink more than 1 drink a day, you're considered not in a moderate drinking area for women, 2 drinks for men. And the significance of that is it's just not healthy. I had a friend who actually is a healthcare professional, and she said, well, I don't drink a lot, but when I do, if I have 3 drinks, is that not okay? And my sort of knee-jerk answer is, well, is it okay to have 3 desserts with dinner? We all know that's not okay, right? But we have no sense of what inappropriate drinking is. So inappropriate drinking, not moderate drinking, is anything over 1 drink per day for women, 2 drinks per day for men. So the best public health message is that from the CDC that if women of childbearing age are having sex and drink alcohol, they are advised to use effective birth control effectively. Now, of course, that's a problem. We know that everyone doesn't use their birth control effectively. We know that everyone doesn't take their pill at the same time every day. We know that some women might be on antibiotics and they take their pill and that ruins the effectiveness. So there are a lot of other issues that go into this. In the United States, the CDC's message is that there is no amount of alcohol consumption that can be considered safe during pregnancy or when trying to get pregnant. That is not a message that's across the world. So that's another significant issue. In Europe, they say it's okay to have 1 drink a day when you're pregnant. So we still have doctors who are saying, oh, you can go ahead and have a drink. We're being too providential in the United States. And it's not, and I'll get to why that's a really bad message for people. Again, all types of alcohol are equally harmful, including all wines and beer. I'll explain that further. Women who are pregnant or who might be pregnant should not drink alcohol. This includes women who are trying to get pregnant. Again, we don't know necessarily day 1 when we're pregnant. It's never too late to stop drinking because brain growth takes place throughout pregnancy. The sooner the drinking is stopped, the better the outcomes for mother and baby, which is why screening is so important. Making sure that somebody who might be drinking during pregnancy understands the risks of that, is screened for that, and is given help for that. Testing, too, makes a huge difference in regards to this. So drinking alcohol during pregnancy can cause lifelong physical, behavioral, and intellectual disabilities. FASDs last a lifetime. There's no cure for FASDs, but early intervention can improve a child's development. So there was an episode, What Would You Do? John Quinones, What Would You Do? And he had a pregnant woman at a bar. She was wearing a baby belly and sitting at a bar, and people were buying. She was drinking. That was the whole point. She was drinking. And the what would you do was, what would you do about this? What would you do if you saw a pregnant woman sitting at a bar, bellying up to the bar, drinking shots? Some women went over there and bought more shots for her. Some people were appalled and tried to say something to her. There were a lot of issues, a lot of different responses that went into that. And it was amazing that not enough people, in my estimation, actually thought it was a problem. Pregnant women can buy a grocery cart full of alcohol and go home and drink it without anybody blinking. But women of childbearing age who have adult acne and need a prescription for Accutane have to show 2 forms of birth control in order to receive that prescription, which again, that is sort of, that tells you where our society is around alcohol. If anyone remembers the Zika virus, the numbers of people who were affected by Zika, pregnant women who were affected by Zika, were much lower than those who were affected by drinking during pregnancy. But we had humongous marketing campaigns to make sure that people weren't getting bit by mosquitoes when they were pregnant. And it's just really kind of sad that we aren't doing a great job of educating people, everybody, about the dangers of drinking during pregnancy. Again, there is no safe amount, but about 1 in 9 pregnant women are reported drinking alcohol in the past 30 days. So the standard drink, a standard drink is 14 grams of alcohol. So it doesn't matter what you're drinking. If you're drinking alcohol, that's a standard. If you're drinking a full drink, it's a standard drink. So I used to do a presentation where I would have a glass, a wine glass, a beer bottle, and a shot glass. I would fill it with water, and I would ask the audience which has more alcohol. Somehow, a lot of people think that more alcohol is in the spirits, the shot or the spirits, shot of brandy, shot of tequila, and that's not the case. Then I would take out my food coloring, my food coloring, and I would put 1 drop of food coloring. That signified the alcohol. So it doesn't matter what the base is. It doesn't matter that I'm drinking a mixed drink. If I have a shot in there, I'm still drinking a full drink. If I drink a glass of wine, I'm still drinking a full drink. Now here's the even bigger problem, especially when somebody says, oh, it's okay to have a glass of wine, or it's okay to drink a little. Well, my little bit of drinking and your little bit of drinking likely are not the same. I actually don't drink at all. But if I did, I would measure my drinks. I would know exactly how much I'm drinking. And that's not what most people do. In fact, the wine glasses, especially the big wine glasses, I know there's a difference between red and white. I think the red ones have the big bulbs on them, big bowls on them. But think about if you went to an establishment, not if you're home pouring your own. If you went to an establishment and you had this great big wine glass and they only gave you 5 ounces of wine, most people would be like, where's the rest of my wine? I know that at VFWs, typically, they over-pour their drinks. If I know that, everybody knows that. So we don't measure our drinks very well. Unless you're drinking a beer, and even that with all the IPAs and the specialty beers now, it's really hard to determine how much alcohol is in there just by drinking a bottle. And then again, or just by buying the bottle and looking at it. And again, if you're not pouring a drink properly, that's not the right amount. So it is really significant that we understand what a standard drink is, but that we also understand that just because I said I had 1 drink doesn't mean I had 1 drink. So the clinical recommendations, we need to educate women of childbearing age about alcohol, contraception, and fetal alcohol spectrum disorders. We need to ensure alcohol screening is done for all women of childbearing age. We need to ensure that SBIRT, the screening, brief intervention, referral to treatment, happens for women at risk, meaning those who indicate that they already have a child who has fetal alcohol spectrum disorder, or those who have a history of alcohol abuse or dependence. We need to ensure that screening and appropriate diagnosis is being done for individuals with possible FASDs, and we need to manage and coordinate their treatments. And we also need to help the families with appropriate services and refer as needed for appropriate services. So the potential effects of alcohol is that there's premature birth, there's pre and postnatal growth retardation, there are physical malformations, there's microencephaly, the small head circumference, and there's cognitive and behavioral problems. A normal brain is shown next to an extreme case of a baby that had fetal alcohol spectrum disorder, had a fetal alcohol spectrum disorder. The smaller the brain, the smaller the head. That's why the microencephaly happens. The impact of alcohol on a developing embryo or fetus. The alcohol readily crosses the placenta, and the fetal liver and organs aren't able to metabolize alcohol. They're not just little adults, right? And then they end up getting a blood alcohol concentration as high as the mom does. Mom is not able to protect that baby from the alcohol crossing the placenta. There are additional manifestations regarding prenatal alcohol exposure for timing, dose, and other fetal and maternal factors. We'll talk a bit about that. There is some catch-up available or possible if the drinking stops at any time during pregnancy. So somebody who figures, well, I already did the damage, I might as well just keep drinking, should be dissuaded from that, because it's not necessarily true. They can catch up. Again, it is brain damage, but that doesn't mean that the brain damage can't change. We know that even having a surgery or other parts of the brain are able to compensate oftentimes. So women who are drinking during pregnancy, we figure that out. We need to encourage them to stop, explain why, and explain that, yes, that the baby that could be damaged, could be. We don't know that either, so that's kind of a problem. But also, even if there is some damage going on, that can be overcome a little bit. Using alcohol during pregnancy is like throwing chaos into what needs to be a highly regulated system. So it astounds me that we're drinking during pregnancy, but we know we shouldn't eat like deli meats, or we know we shouldn't eat sushi. And people know those things, but the drinking during pregnancy is still getting too much leeway. So the amount of exposure, the threshold effect, again, there is no known safe level of alcohol use during pregnancy. We have no idea how much is safe and how much isn't. And again, even if we thought we knew, we're not doing a good job of measuring. So there is no known safe level of alcohol use during pregnancy. The dose response rate, the higher the BAC level, the longer the exposure, the greater the risk to the developing embryo or fetus. So somebody has a significant alcohol use disorder, they're raising their level of blood alcohol concentration, and they're exposing that baby longer, there's going to be a greater risk to that embryo. The timing of the exposure is another sort of unknown. The first trimester, we believe that the risk for major physical abnormalities, characteristic facial features, and the growth retardation and neurological effects happen. The second trimester is a risk for spontaneous abortions, miscarriages, growth retardation, and neurological effects. And that third trimester, there's a risk for the growth retardation and neurological effects as well. So we really think that when the baby is, how the baby is developing during those trimesters is what's being negatively affected. And I'll have a graph a little bit later. Other factors that can exacerbate fetal alcohol spectrum disorders are maternal age. If a woman after 30 is drinking, she has a 2 to 3 times increased risk of having a baby with fetal alcohol spectrum disorder. Gravidity, if a woman already had a baby with a fetal alcohol spectrum disorder in a prior pregnancy, she has a greater chance of having a baby with a fetal alcohol spectrum disorder if she drinks during her pregnancy. And stress. Now, stress is a really big one. So if I've got stress and I'm drinking, the stress causes problems. So animal studies indicate alcohol consumption combined with maternal stress statistically increases rates of miscarriage and stillbirth, along with lower infant behavioral scores. But stress can look different to different people. So poverty is stressful. Trauma, of course, is stressful. So if I'm coping with my stress by drinking, those combinations are going to affect my baby even more. So this is the developmental chart I was talking about. We don't know for sure. This isn't saying absolutely this is the way this is going to work, but the idea is that while the central nervous system, brain, spinal cord is developing during those first 2 trimesters, that's when the most damage is going to be done to the central nervous system, when the heart is developing, and the arms and the legs and the eyes. And so that's why fetal alcohol syndrome has those very specific eyes and oftentimes ears that look different than a child without, because it was the drinking was happening at an earlier time in the pregnancy, is the idea. We're, again, not absolutely positive about this, but pretty sure. Alcohol use during pregnancy leads to lifelong effects. Again, 1 in 20 school children may have FASDs. That number may be low. That's a conservative estimate. People with FASDs experience a mix of the following problems. They have physical issues, they have behavioral and intellectual disabilities, and then they have lifelong issues. And we're going to get into these in more detail. I do want to point out that our prisons are filled with people with undiagnosed FASDs. We've done a terrible job helping people understand what's going on with them and developing plans to get them on a right path. Again, there's a lot of stigma that goes with this, but we need to talk about this more and have people realize how significant it is. So the impact of fetal alcohol spectrum disorders: delayed development, hyperactivity, learning disabilities, behavioral problems. And again, we are underdiagnosing FASDs and treating the cough instead of treating the pneumonia. So if somebody has a learning disability, they're labeled with a learning disability. So all these other issues are sort of ignored, falling by the wayside, and that's really problematic. Concerns across the lifespan. So an infant who may have a fetal alcohol spectrum disorder has sensory and regulatory problems, irritability, poor sleep and wake cycles, they have failure to thrive, nursing difficulties, and a poor immune function. So it starts out right away. You might not be able to see it in their faces, especially really tiny infants. Obviously, you're not going to see it in their behaviors just because they're babies, but it starts out right away. So these things can pop up, and so they get treated for, they're irritable, they get treated for an allergy, or the failure to thrive, they get treated for an allergy. So that it starts the problems with a lack of diagnosis or a mixed diagnosis start very, very early. Toddlers and preschoolers, it just is a continuation. So they're fidgety and distractible. They have motor delays in both their fine and gross motor skills. They don't remember things that they already learned. They have a failure to comply. They're often called oppositional. These children are oppositional. They're not. They don't understand multiple orders, multiple directions. So we tell little kids, hey, I need you to pick up your toys and brush your teeth and go put your pajamas on and get into bed. And they heard, I'm going to go brush my teeth. And they brush their teeth, and then you go and check on them, and they're playing with all their toys that they were just told to pick up. And that looks to a person who doesn't understand like that child is oppositional, when in fact that child did what he was capable of doing given the directions. They also have a lot of sensory issues. So I once cared for a child who loved to wear corduroys because he liked that feeling of rubbing the corduroy pants because of the sensory issues. These are kids who either like to be touched, don't like to be touched, like to be touched in a certain way. A lot of those what comes off as being just a little odd, again, if we don't know. The concerns lead to attention deficit disorder, again, the oppositional defiant disorder, and the reactive attachment disorder diagnoses. School-age children, they show hyperactivity, attention problems, they have weaknesses in their visual spatial abilities, not a lot of hand-eye coordination. some math problems, some performance IQ versus their verbal IQ. Their verbal IQs tend to be very high or higher average, and so they seem like they would understand what's happening, what's being told to them, but their performance does not show it as well as their verbal acuity. My niece actually has brain damage caused by surgery, so it has nothing to do with fetal alcohol spectrum disorder or fetal alcohol syndrome, but brain damage oftentimes it just is brain damage. And so she has a lot of these same characteristics that are really kind of interesting to see. And the one that just stuns me, she's now in her 30s, but the one that stuns me is her verbal IQ. She's got a great vocabulary. Unfortunately, she doesn't understand what she's saying a good portion of the time. So she'll use the word very correctly. And I'll say, honey, what does that word mean? And she'll say, I don't know. And it's a really bad idea to use that word. Well, for example, my husband, she just said, gosh, I hope he's not terminal. And because he was in the hospital. And she didn't understand that terminal meant he was going to die. And I had to correct her and say, no, sweetheart, he's not terminal. He's sick. He's not terminal. So the verbal looks good and they can use it well, but they're not using it. They don't understand what they're saying very often. So imagine you have a budding adolescent, but he can't accurately understand social rules and expectations. How long do you think it would take before he begins losing friends if he doesn't understand ideas like subtleties of body language and the rolling of eyes when something silly is said or something is not desirable, or the semantics of preteen language, like knowing the difference between something being cool and something being hot, because those are words that obviously they mean the same thing, but a child who has fetal alcohol spectrum disorders may not understand that. The frontal lobe of our brain is the area that's affected by prenatal alcohol exposure. We know that that's the last area of the brain to develop, and it's responsible for executive functioning and abstract reasoning. So understanding nonverbal language like body language requires that executive functioning, and a lot of these children cannot do that. Adolescents and teens, again, there's that executive function that has deficits to it. They're impulsive, very, very, very impulsive. They have poor judgment, and then they are diagnosed with mood disorders and ADD, ADHD. Their poor judgment leads to a lot of scary situations. They don't know stranger danger. They do a bad job discerning who are safe people. That leads to substance use disorder. It leads to teen pregnancy. It leads to suicide. It leads to homelessness, running away. They have a lot of concerns that go into this because of their poor judgment. And I just read an article that I believe it was in Canada. There are gangs who are preying on these children. They find adolescents and teens to do their dirty work based on their disorder, which again, just really scary, but it's something that has to be looked out for. And then adults that those cognitive, behavioral, and functional deficits continue. They have difficulty with abstract reasoning, so they don't understand time, they can't manage money, they oftentimes can't live independently because of that, and so they benefit from case management, vocational support, and housing support. There was a training video where a mom of a daughter who had fetal alcohol syndrome said, every month I help her with her envelopes filled with money for entertainment and rent and food. And every month I think she's going to understand the abstract concept of money. And every month we have to go through it again. So again, it's not willful disobedience. It's not deliberately being oppositional. It's a complete lack of brain function. Give you an example from my own life. My niece does not have fetal alcohol syndrome, but she has this brain damage caused by a surgery. They functionally removed half of her brain. We were at Disneyland, Disney World. We're at Disney World. And my niece wanted to buy one of those villain Barbies. So I had like Ursula from The Little Mermaid and Cruella de Vil. And so let's say there are 10 even. And every time she looked at a row of them, she thought they were all new choices. And we were all really tired, and we all really wanted to go back to my sister's house, and we just want to go to sleep. And she was anguishing over her decision. And I couldn't understand because there were only 10. And, you'd automatically eliminate some of those. So I went over and I was like, hey, what's going on here? She said, oh, she can't choose which one. And so I took like Ursula and Cruella, and I said, okay, between Ursula and Cruella, which one do you like better? And she said, okay, Cruella. And then I would take Cruella and the Wicked Witch of the West. I know she's not a Disney character, but you get my draft. Wicked Witch of the West. Okay, between Cruella and the Wicked Witch of the West, which one do you like better? And we narrowed that down in just a matter of minutes. So again, that sort of, it doesn't seem like that's abstract, but it really is when you're looking at all sorts of things, thinking you have all of those choices. So the FAS Diagnostic Criteria, the criteria for diagnosing specific FAS, full-blown fetal alcohol syndrome, is that there's a height and or weight at or below the 10th percentile. They're smaller. They have those facial anomalies. They have the small palpebral fissures, the eye openings. It looks like their eyes are set farther apart. They're really not. It's just that their eyes are smaller. They have a thin upper lip, mammalian. And then they have a smooth philtrum. The philtrum is those two lines we have for running from our nose to our top lip. They typically don't have that. They don't have to have all of these, but they have some of those. And then there are the central nervous system impairments. The facial anomalies, those are corrected for racial norms. So there's actually a ruler that has pictures of lips. And this is what different races' lips look like. And then it's a ruler to measure those eye spaces and to see if they are actually smaller. It's a 8-hour training to get a medical personnel to be trained. They do have to be at a certain level, but they can be trained and then they can make the diagnosis. Now, there's a reason they're not making those diagnoses, and that's because we don't have any services once that diagnosis is made. We'll talk more about that later, but there are specific criteria that just need to be learned and then can be diagnosed by a medical professional who's been trained. What is not an FAS diagnostic criteria in the United States, and it is elsewhere, it is not in the United States, is that there does not need to be a documentation of prenatal alcohol exposure. That's huge for foster care systems or for adoption systems or for moms who aren't going to be honest. So mom does not have to indicate that she drank while pregnant in order for there to be a diagnosis of fetal alcohol syndrome for the child. Doesn't need to happen. One person can make the diagnosis based on that previous slide, and then that child has a diagnosis of fetal alcohol syndrome. The discriminating features in FAS in a young child are, again, those small eye openings, the flat, elongated philtrum, not those two vertical lines. A short nose, they tend to have a short nose. They tend to have a flattened mid-face, and again, a thin upper lip. I had a case where a woman, we're doing intervention. She said, my sister needs an intervention. We're working on that. And then she came to me and she said, I think my sister has fetal alcohol syndrome. They knew that their mother drank. The sister was in her 30s. And here in Wisconsin, we do have the ability to have adults be screened. So I said, I can help you arrange that if she's willing to do it. She called her sister. She said, would you be willing to have a screening for fetal alcohol syndrome? And the sister said, yeah, that'd be great. Maybe now I can find out why every eye doctor told me that my ears were too long. That is just stunning. Here's a woman, she became a truck driver, she had children of her own, she struggled through life. And I saw like a really grainy throwback Thursday picture of her on social media. And I was, even looking at the picture, I was like, oh my gosh, yeah, she absolutely has fetal alcohol syndrome because it doesn't go away. But she struggled through that. And we have so many people, thankfully for her, she did develop substance use disorder, but thankfully for her, she didn't end up in our prison system, because that's where so many of these people end up, because they have not been screened and served properly. So the impairments, again, fine and gross motor coordination is poor. They have cognitive disabilities. There can be mental retardation. There isn't always mental retardation. That's a huge range of what IQ can be, but there are typically learning disabilities, even if there isn't mental retardation. There are developmental delays, speech and language deficits, memory and processing problems, attention problems, and hyperactivity. Cognition, specific learning disabilities, poor academic achievement, discrepancy between verbal and nonverbal skills, and slowed movements or reaction. They're clumsy. They're not, they're not going to be athletes for the most part. They are overstimulated often. The impact on their executive functioning, poor organization and planning skills, concrete thinking, very concrete thinking. So the things that we say, like, let's go hit the road, doesn't seem like a good idea, because that means we're going to go out and actually put our hands down on the road. They lack inhibition. So there's no stranger danger, leads to a lot of problems. They have poor impulse control, or they lack impulse control, and they have poor judgment. When I do this training in person, I always ask someone in the audience, hey, can I have your phone? And they hand it to me, and I say, well, now it's mine. Because I didn't ask to borrow it. I didn't ask to look at it. You didn't tell me I needed to give it back to you. That's the judgment that happens. So when I pick something up in a grocery store, I forget I'm supposed to pay for it. I may just eat it. And then that lack of judgment leads to other consequences. So those are the kinds of very specific behaviors that have to be addressed with fetal alcohol spectrum disorders. Their motor functioning, they have delayed motor milestones, and they're clumsy, they have some balance problems, and they have some tremors, and they have poor dexterity. They're distractible, they're overactive, they have difficulty completing tasks, they have trouble with transition. So the troubles start really being seen sort of in that middle school range, where they did okay in elementary because they didn't have to move around a lot, but now they're supposed to get from class A to class B in 3 to 5 minutes, and that's problematic. And every person, every child who's diagnosed with fetal alcohol spectrum disorders, not every, I'm exaggerating, but many, their key complaint is that sense of being overwhelmed. They have a real hard time just moving through life. Social skills, again, lack of stranger fear. They're immature. They have superficial interactions. They don't have interactions with, they don't have great friends. They're vulnerable to be taken advantage of. They have an inappropriate choice of friends. Poor perception of social cues. They don't understand the eye rolling. They don't understand, the flipping of the hair. They don't understand a lot of those social cues, which of course leads to all of this other stuff. That's why their interactions are superficial. That's why they don't have great friends. That's why they have to have friends who maybe aren't great choices. And that's why they're taken advantage of. Big problem with regards to diagnosis of fetal alcohol syndrome is that there is no feature of fetal alcohol syndrome that is unique to prenatal alcohol exposure. So the eyes, the philtrum, all of that, there's another diagnosis that could be that instead of FAS. So same with, there are a lot of genetic conditions that include growth retardation in your CNS impairments, the central nervous system impairment. So we can't look to this and say, oh, it's absolutely fetal alcohol syndrome. It has to almost be a diagnosis of removing other things, a diagnosis of elimination. Other syndromes that include those facial features are Williams syndrome, Noonan syndrome, Dubowitz syndrome, and fetal dilatant syndrome. So if you could have a different diagnosis than mom admitting that she drank during pregnancy, people are going to want that. And again, the stigma that goes along with this, but they're not getting all the help they need if we give them a wrong diagnosis, of course. So intervening with people who have FASDs, we need diagnostic services as part of a continuum of services for individuals and their families. So we're not diagnosing. We need a doctor to do that, or a nurse practitioner. We then need a team of people to provide the care. So we need mental health care, mental health clinicians. We need case management. We need education and special education. We need therapy through occupational, physical, speech, language. We need other services for health, and then we need family support and the rest of it, because it's difficult to care for a person who has FASD. So diagnosis is one area we're lacking, but then the other area we're lacking is all of this. We don't have these great teams. And I was just on a conference call, a webinar, where they were talking about, diagnosis is great, but we really need to be able to address the problem. You can't have a bunch of people running around with a diagnosis and then not have any services for them. Unfortunately, we don't have a lot of people doing the services because we have no need for them because there's no diagnosis. So I don't know. I mean, this is really a chicken and an egg conversation, but I really think that we have to address it much better than we are to get anywhere. So intervention strategies for somebody who has a fetal alcohol spectrum disorder is that they need structure and consistency. They need a safe living environment, including food and sleep, and the right kind of food, right? They need good food that's healthy for them, and they need appropriate amounts of sleep during appropriate times, because those are things that are going to be dysregulated. They need concise, explicit instructions. They need a repetition of lessons and steps. They need stable routines. They need visual aids. They need support, and they need a controlled amount of stimulation. Now, think about this. Wouldn't we all really shine if we had all of this going on? So I started in this field, in the substance abuse field, back when all the crack babies, oh my gosh, the cocaine babies are going to be the end of the world. That's going to be the problem. And we later found out that, in fact, those babies, while they were problematic, really it was fetal alcohol spectrum disorders. That was really the cause of all of their bad behaviors. Their negative, bad behaviors. Their negative behaviors that happened because of, yes, the moms would use cocaine, and then to come out of the cocaine, they would then use alcohol so that they could do the things that they needed to and get off of, get away from their high. And we had to take down mold. You couldn't have too much stimulation. You had to give them single tasks, all of the stuff. And I thought, gosh, we would all benefit from this. We would all benefit from less stimulation in our lives and more support. And so I just think that instead of stigmatizing people who need special help, we should all recognize that special help would really open up a new world for everyone. So in summary, many individuals with an FASD experience problems in school and getting along with other children. It is beneficial to obtain an early diagnosis. They may need support and services throughout their lives, and they are at increased risk for victimization and high-risk behaviors. Typically, they will need support and services to live and work independently, but those services aren't readily available, and we need to do a better job to get them. Proof Alliance is doing a great job. That was formerly the Minnesota Organization on Fetal Alcohol Syndrome. So you're interested, check out their website. The university, University of Washington is doing a fantastic job in diagnosing. And to me, it's just really exciting that there is some hope on the horizon. And then that other category, I just gave you the overlapping characteristics so you could see that yourselves better. That's it. That's my information. I'm happy to answer any questions. Feel free to ask.
Thank you, Guida, for a great presentation today. We heard a great deal about the components of FASD, and we're hoping this live webinar will help open up the discussion for testing for alcohol exposure at your facility. At this time, we would like to open up the platform for questions to Guida Brown to answer from our audience. We also have Grace de la Pena, who is the account manager from our adult and child team, to help answer some questions as well. So I do see here that we do have a couple of questions. And the first one, Guida, I'll read this off to you. How do you assess for FASD? We just had an evaluation for our foster daughter, and this was not talked about at all. But she displays the exact behaviors that are being dissembled by the speaker. They immediately went to ADHD.
That's really unfortunate. And thank you for educating yourself, because that's really what it's going to come down to. We have about 100 people on this call. Go tell 2 people each, and eventually we'll get a better system for recognizing this problem. I don't know. This was diagnosed in like 1990. No, 1972 or 1976. How we're still this far behind is beyond me. And I get it's about stigma. I get that. But it's unfortunate because our children are the ones who are suffering. So seriously, go in there with this PowerPoint, or go in there with the information that would educate your pediatrician, because they're the folks who need to know about this, and then educate themselves how to be diagnosticians. Your state probably has that information. I would be happy to try to track that down for you, but the state does have it. The feds have not done a great job of keeping that updated. It's just a slow, arduous process for all of us.
All right, great. Thank you so much for that response, Guida. The next question is, so many of these markers are shared with ADD and ADHD. How do you distinguish one from the other?
So again, I guess that's my example of you're diagnosing or you're treating a cough when you have pneumonia. We have to look into it further. We can't, there are specific characteristics of ADD, ADHD that can be addressed. And then you can look at the bigger picture if there are these other things that are going into it. I'm not an expert on ADHD and ADD. Unfortunately, I'm the expert on FASD, but I'm sure there are other things that a child would have if they have fetal alcohol spectrum disorder. Again, the fetal alcohol syndrome, that becomes really clear, and I can make assumptions really well about kids just seeing them, just going to an event where there are a lot of kids, and I can oh, gee, wow. So we just have to do a better job of knowing what we're looking for. And so if I only have a hammer, everything's a nail. And that's not the case. If I only have Ritalin, everyone's got ADHD. That's not it. We have to really be able to have a hammer and a screwdriver and a wrench and all sorts of tools I don't know about.
We do have a question here that me and Grace de la Pena can answer. What type of testing do you use? What is the earliest age you can do testing for? So as far as with the newborn side of things, we do testing with the umbilical cord tissue and meconium. So umbilical cord tissue, we do the testing for alcohol with ETG, and then for meconium, we do FAEE. And then as far as the ages, it's right when the baby is born. And the look back window is up to 20 weeks. So I'll pass it off to Grace de la Pena to answer for the adult and child side.
Just to reiterate what Teresa stated, we do offer the alcohol testing for the head hair as well as the fingernails for ETG. The look back window for those is up to 3 months. We do offer the dry blood spot testing for PET as well, which is a biomarker for alcohol, and that can go back up to 2 to 4 weeks of detection on alcohol.
All right, thank you so much, Grace, for that response. And I'm so glad you were able to get back to help with our audience with that question. So it looks like we are running out of time. So we're going to conclude the presentation. Thank you so much, Guida and Grace, for answering the questions from our audience today. USDTL will be exhibiting next month at the 2022 FANNP 33rd NNP Symposium in Florida. If you are attending this conference, please stop by our booth and say hello. To keep up with the latest events with USDTL, please visit our website and join our mailing list. Also, we do encourage you to follow us on our socials, such as LinkedIn, Facebook, Twitter, and YouTube. Thank you all for joining us today, and I hope you guys did enjoy this great presentation. Have a great rest of your day. Bye-bye.
Subscribe to our channel to see more videos like this.